Welcome back to the deep dive. Today, we are undertaking a really critical mission. We're aiming for a fast, thorough deep dive into assessing the hematologic system. We're pulling out the key facts, those crucial safety alerts, and the nursing priorities directly from the source material. Think of this as your roadmap if you need to quickly grasp blood cell production and function.
Absolutely. And when we talk hematology, you really have to focus immediately on two, let's say, non-negotiable concepts that impact total body health. These are clotting and perfusion. They're sort of the yin and yang of blood flow. Perfusion is all about delivery, that total arterial blood flow getting oxygen and nutrients out to the tissues, both centrally and way out in the periphery.
And clotting, then, is like the system's emergency brake.
Precisely. Clotting, or we call it hemostasis, it's this really complex multi-step process. It's designed to form a specific protein-based structure, the clot, but only where there's an injury. Its whole purpose is preventing massive bleeding while, and this is key, making sure that vital perfusion keeps going everywhere else. It's a very delicate balance.
Right, that tightrope walk. Keeping blood flowing smoothly, but being able to instantly patch a leak. That seems to be the core theme here. So let's start at the beginning. Where does all this stuff get made? The anatomy, the production factory.
Okay, that factory is the bone marrow. This is the functional site of blood formation. It's churning out red blood cells, RBCs, white blood cells, WBCs, and platelets. It all begins with these immature blood stem cells. Think of them as completely unspecialized blank slates. Then, depending on what the body actually needs right then, they become committed stem cells, guided by specific growth factors to become one type of cell or another.
And you mentioned balance earlier. Does this production stay constant throughout life? I thought it slows down with age.
It does, yeah. As we get older, fatty tissue gradually starts to replace the active red bone marrow. So overall production capacity is reduced in older adults. It tends to remain active mostly in the flat bones, like the pelvis and just the ends of the long bones. This definitely has implications for what we consider a normal baseline cell count in older individuals.
Okay, so bone marrow is the factory. What about the products flowing through the vessels? Let's talk about the liquid part first, plasma. It's packed with proteins, right?
Packed is right. There are three major types, each with a really distinct job. Albumin is the big one for maintaining osmotic pressure. It's the protein that basically keeps the fluid inside the blood vessels, stopping it from leaking out into the tissues. Then you've got globulins. They do transport jobs, carry things around. And some are antibodies, critical for immunity. And finally, fibrinogen. This one's super important because it's the inactive raw material that gets turned into fibrin, the actual mesh for clots.
Got it. And the main job of the solid bits, the cells, is oxygen delivery, right? Those red blood cells, remember they have that unique shape, biconcave, no nucleus, lets them squeeze through tiny capillaries.
Exactly. Perfectly engineered for the job. And their entire function hinges on hemoglobin, or HGB. That's the molecule inside the RBC, and iron is absolutely essential for it because iron is where the oxygen actually binds. HEB's ability to bind oxygen loosely is what allows it to pick it up in the lungs and then, crucially, release it, quickly dissociate when the blood reaches tissues that are low on oxygen, hypoxic.
So if the body senses that hypoxia, that low oxygen level, how does it signal back to the factory, the bone marrow, to ramp up production?
That process is called erythropoiesis. What's really fascinating is that the sensor organ is the kidney. The kidney detects the tissue's need for more oxygen. In response, it releases a growth factor called erythropoietin. That erythropoietin travels to the bone marrow and basically tells it, hey, make more red blood cells. This is why, for instance, a patient with severe chronic kidney disease almost always develops anemia. Even if they eat enough iron, their kidneys can't make enough erythropoietin.
And you need the building blocks too, right? It's not just the signal.
Absolutely. You need the raw materials. If the body is missing things like iron, vitamin B12, folic acid, or even copper, the marrow just can't produce functional RBCs. That leads to anemia, which is basically a reduced number or reduced function of those RBCs. And we also can't forget platelets. They're made from giant precursor cells called megakaryocytes, and their production is controlled by a different hormone, thrombopoietin. Platelets are key for plugging holes.
Okay, quickly then, the accessory organs involved. The spleen acts like a filter or recycler.
Yeah, it's like the recycling center and also a storage unit. The spleen breaks down old, worn-out RBCs. It also plays a role in immunity through its white pulp section. And critically, it stores about 20% of your body's total platelet count. Quick safety point here. If someone has had their spleen removed, a splenectomy, they are at a significantly higher risk for infections. Their immune surveillance is lowered.
And the liver, that's more on the clotting side of things.
Definitely. The liver is a major player in clotting. It produces prothrombin and several other key clotting factors. Factor 7, IX, and X are big ones. And really important, making these factors requires vitamin K. The liver also stores iron in the form of ferritin. So think about it. If a patient has severe liver disease, maybe from chronic alcoholism, their ability to form clots is going to be seriously compromised.
Okay, let's pivot to the main event then, hemostasis. This controlled, localized clotting. It's a sequence, right? Starts with platelets.
Yes, first step is platelet aggregation. When a vessel is injured, platelets rushing by get activated, often by exposed collagen or substances like ADP released to the site. They become sticky, clump together, and form a temporary plug. It's like the first responders arriving. But this initial plug isn't super strong. The real reinforcement comes for the next phase, the blood clotting cascade.
Ah, the cascade. This is where things really amplify, like a landslide effect. How does it get
Mhm.
started?
Well, there are kind of two main doorways into the cascade. There's the extrinsic pathway. Think external trauma, something cuts the vessel from the outside, exposing tissue factors. This pathway is fast. Then there's the intrinsic pathway. Think internal issues, maybe damage inside the vessel wall, or turbulent blood flow like in venous stasis, or even just certain substances in the blood itself. This one's a bit slower to activate.
But extrinsic or intrinsic, they both funnel towards the same outcome, right?
Exactly. They merge into what's called the common pathway. Both rely on a series of inactive clotting factors, proteins usually floating around in the blood, identified by Roman numerals. Many of these, like we said, depend on vitamin K for their synthesis in the liver. And calcium is also essential for several steps. These factors activate each other in a specific sequence, like dominoes falling. This culminates in the final, absolutely critical step, fibrin clot formation. The enzyme thrombin, which is activated factor 2, acts on fibrinogen, factor 1, converting it from its soluble form into active fibrin threads. These fibrin threads then link together, forming a strong, stable mesh that traps blood cells and reinforces the initial platelet plug. That's your true clot.
Okay, wow. So if this cascade is so powerful, almost explosive, what stops it from just continuing? Why doesn't the whole blood vessel or even the whole body clot up once it starts?
That is a brilliant question, and the body has built-in checks and balances. These are the anticlotting forces. Their job is to keep the clot localized only to the area of injury. We have specific proteins like protein C, protein S, and antithrombin III. These actively circulate and inactivate key clotting factors, particularly thrombin and factor ZA. Think about this. If someone has a deficiency in protein C or S, their risk for unwanted clots, VTE, venous thromboembolism, like DVTs, PEs, even heart attacks or strokes, goes way, way up.
Okay, so anti-clotting forces prevent it from spreading, but what happens to the clot once the vessel is healed? Does it just stay there?
No, it needs to be broken down. That process is called fibrinolysis. It's basically clot dissolution. There's another inactive protein called plasminogen circulating in the blood. When the time is right, it gets activated into plasmin. Plasmin is like a molecular scissors. It specifically digests the fibrin strands, breaking down the clot. And this leads to a really important clinical distinction you need to understand. Anticoagulant drugs, like warfarin, Coumadin, or heparin, they work by interfering with the clotting cascade factors. They prevent new clots from forming or existing clots from getting bigger.
They don't break down existing clots.
Exactly. They are not clot busters. The drugs that do break down existing clots are the fibrinolytic drugs, sometimes called thrombolytics. They work by activating plasminogen to plasmin. Big difference in mechanism and use.
That's a super important distinction. Okay, let's shift gears to assessment. We need to start with the natural changes with aging. What should we expect?
Well, as we discussed, that bone marrow activity slows down a bit. So older adults often present with slightly lower total red blood cell and white blood cell counts. Hemoglobin levels also typically tend to fall gradually after middle age. And you might also see decreased overall blood volume and potentially lower levels of plasma proteins like albumin, which can be related to nutritional changes or just reduced liver function over time.
Okay, so when we're taking a nursing patient history, gathering those subjective cues, what are some red flags or key areas to ask about?
Definitely consider biological sex. Women, especially during their reproductive years due to menstruation, often have naturally lower RBC counts and hemoglobin levels. Drug history is huge. You must meticulously check for all current and recent drug use. Specifically ask about anticoagulants, obviously, but also things people forget, like common over-the-counter NSAIDs aspirin, ibuprofen. These interfere with platelet function.
Good point. And diet seems like it would be a big factor too.
Oh, absolutely. Nutritional deficiencies are a common cause of hematologic problems. Lack of iron, vitamin B12, or folate leads to different types of anemia. Interestingly, on the flip side, if someone eats a lot of vitamin K found in leafy green vegetables that can actually increase their blood clotting rate, this is a critical interaction to know about if they're taking warfarin, for example. And we mentioned the liver chronic alcoholism is a double whammy. It impairs liver function, so factor production goes down, and it often leads to poor nutrition.
If we suspect anemia based on history or labs, what's the symptom that usually brings people in? Is there one main thing?
Overwhelmingly, it's profound fatigue. And we need to differentiate this. It's not just feeling tired, it's that deep energy-draining fatigue. It happens because with fewer or less functional RBCs, oxygen delivery drops. Cells can't make enough ATP energy, so you look for loss of endurance, maybe feeling dizzy or lightheaded, vertigo, ringing in the ears, tinnitus. Even specific things like a sore, smooth tongue can be a clue for certain anemias. And always ask about family history. Any genetic risks like hemophilia, sickle cell disease, or maybe a family tendency for easy bruising, frequent nosebleeds, or conversely, excessive clotting.
Okay, moving to the hands-on physical assessment. There are some major safety priorities here, right? Two big ones stick out.
Yes. The first one is fundamental but critical. Handle the patient gently. If you suspect any kind of bleeding disorder or low platelets, you must be careful to avoid causing bruises, ecchymosis, or those little pinpoint hemorrhages, petechiae. When you inspect the skin, look for generalized pallor. The most reliable places to check are where the skin is thin and capillaries are visible, the gums, the conjunctivae of the eyes, and the creases on the palms. Also check for jaundice, which could indicate excessive RBC breakdown.
And what about assessing skin changes in patients with darker skin tones? Pallor can be harder to see.
That's a key cultural consideration. For pallor or cyanosis, bluish tint, in individuals with darker skin, the best places to look are the oral mucous membranes inside the mouth and the conjunctivae. For petechiae, those tiny reddish-purple dots, you might only see them on the palms of the hands or the soles of the feet.
Makes sense. Now, if oxygen delivery is down because of anemia, the heart and lungs try to compensate immediately. What signs would we see?
Right, the body tries to make up for it. The heart works harder, which might result in weak, thready pulses, maybe tachycardia, or even irregular heart rhythms. In severe anemia, the blood volume might be lower, so systolic blood pressure could actually drop. The lungs also work harder. You'll see an increased respiratory rate, shortness of breath, especially with activity, dyspnea on exertion. A classic cue is asking the patient to speak. Can they complete a sentence of, say, 10 words without needing to pause for breath? If not, that's significant.
Okay, and now for that absolute life or death safety alert regarding the physical exam, the abdominal assessment piece.
This one cannot be stressed enough. You must never palpate the splenic area, that's the left upper quadrant of the abdomen, if you suspect a hematologic disorder. The spleen also becomes enlarged, splenomegaly, in these conditions, and an enlarged spleen is extremely fragile. It can rupture very easily with even gentle pressure. A ruptured spleen leads to massive internal hemorrhage, shock, and potentially death within minutes. It is absolutely a hands-off zone during palpation if hematologic issues are suspected.
Wow. Okay, message received. That's incredibly important. Let's wrap up with the diagnostic deep dive. The CBC, the complete blood count, seems like the starting point for everything.
It really is the foundation. The CBC gives us the raw counts, RBCs, WBCs, platelets, but just as important are the percentages and indices. You get hematocrit, which is the percentage of the total blood volume that's made up of red blood cells, and hemoglobin, the actual measure of the oxygen-carrying protein in grams per deciliter. But to figure out why someone might be anemic, we need to look deeper at the RBC features.
Right, like the size and color of the cells.
Exactly. We look at the MCV, the mean corpuscular volume. This tells you the average size of the red blood cells. A high MCV means the cells are macrocytic, too large, like in B12 deficiency. A low MCV means they're microcytic, too small, often seen in iron deficiency anemia. Then there's the MCHC, mean corpuscular hemoglobin concentration. This measures the percentage of hemoglobin within each cell, basically its color intensity. A low MCHC means the cells are hypochromic, paler than normal.
And what about the reticulocyte count? What does that tell us?
Reticulocytes are basically baby red blood cells, slightly immature ones just released from the bone marrow. So an elevated reticulocyte count is usually a good sign in the context of anemia or after bleeding. It tells you the bone marrow factory is responding appropriately, it's revved up, and actively trying to replace the needed cells.
We talked about platelets earlier. Low count is thrombocytopenia. You mentioned it increases bleeding risk. Is there a critical level we need to watch for?
Yes, normal platelet count is roughly 150,000 to 400,000 per cubic millimeter. If that count drops below 20,000, maybe even 10,000, The patient is at extremely high risk for spontaneous, potentially life-threatening bleeding like intracranial hemorrhage or massive GI bleeding that can happen without any apparent injury. It's a critical value.
Okay, shifting to coagulation tests. These look at those pathways we discussed, the intrinsic and extrinsic.
Correct. The PT, or prothrombin time, primarily measures factors in the extrinsic and common pathways, factors 2, V7X. It's typically around 11 to 12.5 seconds normally. Because PT results can vary slightly between labs, we use the INR, the International Normalized Ratio, to standardize it. The INR is what you primarily monitor for patients on warfarin therapy, usually aiming for a therapeutic range of 2.0 to 3.0 depending on the indication. Then you have the PTT, or partial thromboplastin time. This assesses the intrinsic and common pathways, factors 2, V8, 9, XC11, 12. A prolonged PTT can indicate things like hemophilia or severe liver disease. It's also the main test used to monitor standard unfractionated heparin therapy. A related test, antifactors Axol, is often used now too, especially for monitoring low molecular weight heparins. And a crucial safety point for any blood draw, any venipuncture on a patient with a known or suspected bleeding problem. After you draw the needle, you must apply firm, direct pressure to the site for at least 5 minutes to prevent hematoma formation.
Good practical tip. So, if these blood tests aren't giving the full picture, the next step might be more invasive. Bone marrow aspiration and biopsy.
Yes, if we need to see exactly what's happening inside the factory, how cells are being produced and maturing, we might need a bone marrow sample. It's usually taken from the posterior iliac crest, hip bone, sometimes the sternum. It involves getting both a liquid aspirate and a small, solid core biopsy. Patient preparation is key here, mostly for anxiety. You need to explain what they'll feel. The initial sting of the local anesthetic, then a feeling of heavy pressure or pushing as the needle is inserted. The most uncomfortable part for many is a brief, but often quite painful pulling or sucking sensation when the liquid marrow is aspirated. Forewarning them helps immensely. And it goes without saying, sterile technique is absolutely non-negotiable during the procedure to prevent osteomyelitis.
And after the procedure, what's the absolute top nursing priority?
Prevention of excessive bleeding from the site. That is priority number 1. Apply direct external pressure immediately after the needles are withdrawn. A pressure dressing is applied. Sometimes even small sandbags are used for extra pressure, especially if platelet counts are low. Post-procedure instructions are vital. The patient needs to inspect the site every 2 hours for the first 24 hours for any signs of bleeding or bruising. They should avoid any trauma or strenuous activity involving that site for at least 48 hours. And for pain relief, make sure they know to use only an aspirin-free analgesic like acetaminophen because aspirin affects platelets.
This whole deep dive really hammers home that core concept, doesn't it? The entire hematologic system revolves around that delicate balance between clotting and perfusion.
It absolutely does. And successful nursing assessment relies on connecting those physical cues. We see the fatigue, the pallor, maybe the shortness of breath, the low BP with the diagnostic lab results that tell us why, the size, the color, the number of cells. The diagnostics explain the symptoms.
So let's leave our listeners with a final thought, something to really cement the safety aspect we've stressed throughout. If you walk into a patient's room and you have confirmed information, say, you just got the lab result that their platelet count is critically low, under 20,000. Considering everything we've just discussed, what is the single most important action, the absolute first priority you must focus on, overriding almost everything else for that moment?
Without a doubt, it's ensuring patient safety by preventing trauma and subsequent hemorrhage. Every single interaction, every move you help them make, every procedure considered, even just walking in the room, it all has to be filtered through the lens of how do I prevent injury? How do I prevent bleeding? That becomes the absolute top priority.
A truly critical takeaway. Thank you so much for walking us through that. And thank you for diving in with us today to get a handle on assessing the complex hematologic system. We really hope this helps you prioritize your care and feel more confident in practice.